Today I'm going to talk a little bit about our recent work on contactless patient positioning. So the main motivation of our work is to better protect the medical professionals. So as we know, in US, thousands of medical professionals are infected with coronavirus during the COVID-19, and more than 26 die. And so one critical question we want to ask is how we can minimize their exposure to virus during medical scans. So as we know, CT and X-ray, these are the two main modalities used to diagnose COVID-19. And take CT as an scanning process. The technicians or radiology, they are heavily involved in the scanning workflow. So for example, the technician has to guide the patient to pose on the patient support. And then also, once the patient is in position, the technician has to determine the scanning parameters, for example, starting position and end position, and also the bed alignment based on the observation of the body shape and the pose of the patient. So there are lots of physical interactions and involved in this process. So that puts our technicians in a very risky position with exposure to the virus. And also due to the shortage of PPEs, the PPEs become very, very rare resource, and it has a very high demand. And so a side question we want to ask is how we can save the usage of PPEs during in hospital environments. So another question we're facing is the healthcare system is overwhelmed. So take China as an example. Each CT technician has to scan more than 100 patients daily. Yeah, and that's lots of scans. And how we can automate the scanning process and improve the throughput becomes very critical during the pandemic. Yeah. So one solution we propose to these questions is a automated patient positioning workflow. So the workflow we have in mind looks like this. So imagine we have a smart camera mounted on the ceiling of the scan room, which can take RGB or RGB plus depth multimodality data from the camera of the patient. And then based on the image data, we can detect the anatomical landmarks on the patient and estimate the pose of the patient. And at the same time, we can estimate the body shape of the patient. And based on all this information, we can convert this information into scanning parameters. And then the whole process become fully automated without any involvement of the technicians. And this is what this kind of system looks like in the real world. Yeah, so as you can see that the patient and the technician, they're in the separated room. The patient is in the scan room and the technician is in the control room, overseeing the scanning process and verifying the automated generated scanning parameters by the AI algorithm. So this essentially becomes a contactless patient positioning workflow, which will be very useful in the pandemic situation to reduce or minimize the contact or interaction between the patients and the technicians. So you may wonder what the smart camera looks like. It looks like this. So it's like a size of your hand. So we have 2D or 3D cameras, of course, and then also on the same smart camera we have it's a completely self-contained system with all the computation and communication modules. So which can generate on top of the RGB and depth images, it can also generate the 3D human model from the AI algorithm, including the anatomical landmarks and the body shape information. So you can just plug in this camera and connect it to the CT scanners, and it can start working and convert your conventional CT scanning workflow into a contactless workflow. This is the overview of the system. So as we mentioned, the system takes in multimodality data. Here we are not specifying because it can virtually work with, for example, RGB plus depth data or RGB plus thermal data. Yeah. And once we get the multimodality data, we can conduct the detection and the dynamic multimodal mesh inference to get um, the body shape and pose parameters of the patient, followed by a 3D mesh optimizer to fine tune the parameters we obtain. Uh, and this is an illustration of the process. Yeah, so initially, after the regression, the model we recover from the patient may not be perfect. So it requires some fine tuning and combining the detection results and the regress body shape of the patient. We can obtain optimized results. So it can fit, so the regress body shape data fits the detection results better. And based on the optimized 3D patient model, we can essentially convert this information into scanning parameters. Like I mentioned, the starting point and the end point of the scan, and also the isocenter alignment in order to get the optimal image qualities. And after this, of course, we also have to rely on the camera camera scanner calibration information to convert the image-based detection results into a actual 3D scan parameters for the technician to verify before triggering the scan. And once the technician verifies the automated generated scan parameters, um, this information will be converted into control signals to trigger the actual scan. So this way, we have the assurance from the technician, making sure that the scanning parameters generated by the algorithms are correct. So this is what the user interface looks like for the technician's verification. So as you can see, by modeling the patient body, we can generate based on the scanning protocol. In this case, the test scan. We can generate the scanning region of the CT scan, which is highlighted here in the semi-transparent blue bounding box. So the technician can essentially verify whether this is satisfactory, and he or she can make adjustments if necessary. But of course, since the camera is mounted on the ceiling of the scan room, sometimes it's a bit tricky because of the perspective distortion. So sometimes it's a little bit difficult for the technician to see whether the highlighted scanning region is actually covering the whole body part that the current scanning protocol is requiring. So usually in the traditional workflow, the technician is going to look from a side view of the patient, basically from a level kind of a viewpoint to look at the patient in order to make sure either the bed alignment or the scanning range is reasonable. But in this case, because the camera is mounted on the ceiling, due to the perspective distortion, it's difficult to do. So that's why based on the 3D data, 3D image data, we can essentially generate a synthetic side view of the original image. So it's not like we are adding another camera on the side, but basically based on the 3D or 2.5D data we obtain from the camera, we can synthesize a virtual viewpoint looking at the patient from the side view, so that it's easier for the technician to verify the actual scanning region and the bed alignment. So for example, in this case, the green lines are actually the detection result from the algorithm, but this two lines projection on the bed level is actually the white light. So from the side view, the technician can see that these two white lines are actually aligned with the region of interest, which is the chest area, based on the scanning protocol. And also, and this is the only way that we can visualize the bed alignment result. And also for the technician to make any necessary adjustment from the interface in the remote scanning setting. And now I'm gonna talk about a little more details on the 3D patient model recovery algorithm we developed. And this algorithm is based on a assumption of a parametric 3D human model, which is a skin multi-person linear model. Yeah. So with this model, we can effectively model human of different shape and 3D pose. And also from the model, we can derive a list of anatomical landmarks. And this is not essentially a limitation of this model, because we can always define new anatomical landmarks based on specific application needs from the mesh model, because we have the full 3D mesh model of the patient. And this is what the algorithm pipeline looks like. So we take in two modalities of data from the camera. And then we have a feature fusion module. So the use of a feature fusion module is basically because we want to make sure whatever we develop is flexible and generic enough to suit the need of the various kinds of application and scenarios. So we call this model robust dynamic fusion. So the robust dynamic fusion model enables the positioning model to be trained once with all the possible data modalities. For example, in this case, it can be RGB and depth, or it can be RGB and thermal. And then the model, once trained, can be used across different applications, which may have differing data requirements. So for example, in some scenarios, you may not have the depth data available from your sensor. And in some scenarios, you may only have depth data available from the sensors. So for all these kinds of scenarios, this trained model can work at runtime without significant performance degradation. I'm going to talk about more details later on. And after the feature fusion, we are enforcing three kinds of constraints on the regressed patient model parameters. So the first of all is first constraint is we directly enforce the consistency between the regress patient model parameters with any available patient model parameters annotations we have. This can be the ground truth or can be kinds of pseudo annotations. And then we also, I mean, it's a low-hanging fruit to obtain 2D landmark annotations for the image data. So a straightforward constraint we can enforce here is the 2D landmark projection. So basically, once we obtain the 3D mesh model of the patient, we can project it into the image space and then compare with the 2D annotations we have, the skeletal 2D annotation of the human pose, as we can see here. But on top of that, so because we have depth data available as one of the input modalities, we can also enforce a higher level constraint, for example, 3D constraints. But most of the time, we probably don't have accurate 3D annotations for the data we have. And even if we have the 3D annotations, the 3D annotations may not be defined in the same work coordinate system across different data sets. So that's why we propose a new constraint that's called depth ranking consistency loss, which is combining the depth data we have and the 2D annotations of the human pose and convert it into a near 3D annotation. Basically, we look at the depth ranking of each individual anatomical landmarks in the image and enforce the same consistency constraint on the regressed patient model and the annotation we have. And this way, we can make sure the depth ambiguity can be alleviated during the training process. So we evaluated our pipeline on 4 data sets, so including 2 public data sets on RGBD in a general setting, that's PKU and CAD. And also we collected a large data set from a CT scenario, which we call scan RGBD and RGB data sets. And we also evaluated on a RGB plus thermal data set that's called SLP. And this is in also a clinical scenario which with patients covered by different kinds of materials, thin blanket or thick blankets. So this is also a common scenario we may encounter in the scanning environment. A lot of the patients are covered by blankets during the scan. So this is some qualitative results on the scan RGBD dataset. As you can see that from the RGB and the depth data we obtained from the smart camera, we can precisely recover not just the 3D pose, but also the body shape of the patient. Even under some very challenging scenarios, for example, in this case, the patient's head is covered in the hood, and we can still reasonably precisely recovering the head position and pose of the patient. And here are more qualitative results. An interesting thing to see is that, like I mentioned, even if the model is trained with RGB and depth data at the same time, in the inference time, when one of the modality is missing, the model can still infer and generate reasonable results. As you can see here, when only RGB data is available, and only when only depth data is available, or when both RGB and depth data are both available. The results are, of course, when both of the modality are available, the results is best, but you can see the degradation is quite minor when one of the modalities is missing. And same applies to the thermal data, RGB plus thermal data. In this case, even when the patient is covered in blanket, we can precisely recover the pose of the patient under the cover. And here are some quantitative results on the 4 data sets we evaluated on. And we are comparing our performance to the state-of-the-art human mesh recovery algorithm that's called HMR. HMR was designed for general settings, human pose and mesh recovery. And as you can see that our proposed approach RDF outperform HMR in all kinds of settings, even when one of the modalities is missing. For example, here, the model is trained with RGB and thermal, and we evaluated the results when only RGB is available or thermal is available. And still the performance is very comparable to when both RGB and thermal are available for HMR. And in the case of CAD and PKU, even when one of the modalities is missing, the performance we can obtain with our algorithm outperforms HMR when RGB and depth are both available. So we also conducted an ablation study to show the efficacy of the depth ranking consistency and the feature fusion we propose, showing superior performance on all the data sets. So I mentioned that after the regress parameters are obtained, we also have the optimization module to iteratively fine-tune the recovered patient parameters. And so here we compare 2 different approaches. So one approach is based on a existing approach called Simplify. Simplify is basically taking the detection results and the regress patient parameters and iteratively trying to fit the regress 3D patient model parameters to the detection results, just so that the anatomical landmarks locations matches across the detection and the regress patient model parameters. So this is this has proven to be effective in fine-tuning the regress results of the patient model. However, it's a little bit time-consuming, as you can see that without using Simplify, using only the RDF we propose, we can achieve a frame rate of 66 FPS. But with the Simplify in the loop, the frame rate drops significantly to lower than 1 frames per second. So yeah, in order to improve this, we have proposed a RDF OPT optimization pipeline based on regression. So we are trying to use regression to approximate Simplify. Yeah. As you can see in this table, we have compared the RDF OPT results to the RDF with Simplify optimization in the loop. RDF OPT can obtain similar kinds of per joint error compared to Simplify. However, we don't have that much of a frame rate drop comparing to Simplify. So as you can see on the 4 data sets, we can maintain similar level of frame rate compared to RDF without any optimization module. So in the real world scenarios, the frame rate is very important because for CT and X-ray scan process, a real-time processing speed is preferred. Yeah. And also lastly, we also showed we also want to quantify the robustness of our algorithm to noise. So we vary the probability of a particular modality missing at the test time. So with probability P, basically the x-axis here, we replace each modality, each image of the modality with a 0 array. Basically, we black out a random modalities during the test time. And we can see that both HMR and our RDF model, the performance go down as the noise level increase, which is as expected. However, the degradation is much less for RDF compared to HMR. This is suggesting that the proposed RDF model has a better robustness with respect to noise. And this is demonstrating a very important practical aspect for a robust system deployment in the real world. And here are more qualitative results. And we have shown that the model works well with patient wearing masks, which is a very common scenario during the pandemic. And also we demonstrated the model also works in a general setting, in a more general setting, for example, X-ray scanning workflow, which demonstrating that the proposed model can also work, can be applicable in an X-ray scan scenario. And you may wonder how the system works in real world. So, so far, United Imaging has deployed successfully multiple systems in multiple locations, multiple hospitals in Wuhan and Shanghai in China. And so far, we are receiving very positive feedbacks from the technicians and the radiologists. And we hope that this kind of system can become more popular and can help to protect more technicians in the future. To summarize, we have designed and developed a contactless patient positioning system, and we describe the design and development of the system components in enabling the remote scanning. And we have proposed a novel approach to recover the 3D patient model from a multimodal image data. And we have conducted extensive evaluation on several data sets in both general settings and clinical settings. And we also showed that how it can be applied to various applications during the COVID-19. So for more details, I invite you to check out our paper to appear in DMI. And thank you for your attention.